obesity and diabetes, what are the lacunae of available therapies that we have for treatment, including non-availability of the only FDA-approved drug? And how do you treat patients with this apart from recommending weight loss through lifestyle measures?
It's a fantastic question, and certainly there is a big change in the paradigm from treating NAFLD or steatohepatitis back in UK to India, because the metabolic syndrome is evolving and changing as we go along, and the diagnostic indications has also been progressed in the last 5 years. As you can see, the availability of FibroScan has become rampant nowadays. And I just want to raise one question to the endocrinologist here. How many of you has got access to FibroScan? Can they raise their hands up?
We don't do ask them, but our colleagues.
I mean, of course, I mean to say the accessibility. Everybody's doing it. That's fantastic. The reason is that, I'm going to answer your question in a second, because the question is that every ultrasound comes with a fatty liver 1, 2, 3, and the patient gets scared. And the metabolic syndrome is very high. Just give you an example. My own mother, who is diabetic, I can't treat her diabetes because she never listens. Her HbA1c is 11.2. And she constantly says, I don't eat non-vegetarian, whatever XYZ. She had a fundoplication 2 months ago. She's got a cirrhosis. None of those tests has proved, especially the biological tests or anything like that. And I didn't tell her that she got cirrhosis. And I had the same example last week. Another lady who's got a BMI of 36 went for fundoplication, and then she's got cirrhosis too. So what I mean to say is that the radiological tests or whatever the physiological test we have, is it really true? But the metabolic syndrome is very, very high. So I used to get around 20% of my patients with, there in NHS, we have a system where the liver enzymes goes up. The first thing they refer to me, 20% of my care comes from there. So some of them are alcoholics. So we just change the lifestyle modification. If the AST, ALT is more than 100, I observe for a month and it's still going up. I get a FibroScan and liver biopsy to look at the fibrosis. But having said this, the metabolic syndrome is even very rampant here, which makes it quite concerning. Especially, I gave my own personal examples of my own mother, saying that it's not showing in the biochemical markers or in the other scans. So how do we change it? So certainly, we have evolving methods of treatment that's available at the moment. So going back to Dr. Amar's question, if the patient is diabetic, if he considers bariatric surgery, I would directly convince them for a bypass rather than a sleeve.
This generally, I do sleeve and bypass combinations mainly. Sleeve only for teenagers and unmarried females, or those who don't have much weight, like less than 40 BMI. So most of my surgeries are sleeve and bypass combination, that is sleeve with loop renal switch and sleeve with general bypass, where diabetes condition is very high. So that's why I go for those sleeve and bypass combination. And one more point regarding Dr. Jansen was telling about the FibroScan. So what we have seen is radiology, just ultrasound scan is going to underdiagnose like liver parameters. So if they give a grade 1 and grade 2 fatty liver, when we go inside, it will be grade 3 with fibrosis, or some people will be having cirrhosis liver also, which will not be diagnosed before with routine scan. So just don't go with the findings of like radiological scan findings, grade 1, grade 2, grade 3, it doesn't diagnose properly.
Excellent, Dr. Amar, because you are the one who's going to see the liver every time you put your scope through. So that's why I want you to answer this question, because this is like an iceberg phenomenon. What we find on the existing parameters at the moment is much more beyond than what he might have seen. And it would be quite good to see your own data. I'm sure you've done a lot more laparoscopies, and if you can put the